At least I can like introduce you, and then yeah.
Okay, so has that come up on your screen?
Yes, I can see this very clearly. Yes, thank you very much.
Good. Thank you. I'll just check that it moves forward and back. No,
Okay.
Doesn't want to.
So shall we have the question and answer session at the end, or how are we going to do this?
Yeah, maybe towards the end, but if anybody's got anything as I'm going along that they're unsure of, then please let me know.
Okay, sure.
Now this won't bring my PowerPoint forward and back, so I'll just have to hop out of this one and try again.
So once you're ready, we can start. Well, we have like 56 participants, so alhamdulillah.
Okie dokie. I'm just going to pop out and put this back up because I can't see my little cursor to...
No worries, no worries. Take your time, Wendy.
There it is. No, it is playing up. So it is just the... so it won't be a minute.
No worries.
Doesn't want to go forward and backwards. Sorry, guys. My little cursor's just disappeared off the screen, so that's why I'm having a little bit of trouble with it now. I think it's coming up and it's so wide on the screen that I can't quite see it.
Yeah, probably.
Not, I'll be able to talk it through.
Yeah. How do I pronounce your last name?
It is Duperouzel.
Duperouzel, okay.
Yeah. Oh, you did well. You did very well.
Duperouzel. Is it Italian? Is it Italian surname? Italian name?
It is French background.
Okay, okay, French. Wow. Okay. Duperouzel.
It's still not going to let me out. But...
Once you're ready, I'll introduce you.
Yeah, certainly. I don't think it's just going to work going back and forth, so I apologise about that, but I'll be able to talk it through for you, and I'll be able to send you through the slides so that everybody can see those for you. So I do apologise about that. It just has frozen on the screen and I can't get it to progress any further.
So you're just going to be explaining to us? Is that how we're going to go with it?
Yes, yeah, I'll talk it through, and hopefully at some stage it might kick into
if you need time to unlock and come again, that's okay.
Okay, well, I might try that.
Okay, you just try that and then we'll accept you. While doing that, would it be okay if I like introduce?
Yes.
Okay. I'll be speaking Malay and also English, yeah? In between.
Yep, sure.
Okay. Okay, Assalamualaikum dan selamat petang semua ya. It's really good to have all of you here. And alhamdulillah, we have Wendy Duperouzel. Wendy is actually a nurse she have worked in orthopedic trauma at the Perth Hospital, and she have 14 years of experience as nurse educator, and also she's a coordinator for both the orthopedic and the acute care stream of the Master of Clinical Nursing program at Curtin University. So you can see there's a lot of contribution here towards orthopedic nursing and nursing itself, that comes from Wendy itself. And also she have published a book on adult lower limb traction. Oh, you have a book, Wendy?
Yeah.
Wow, okay. Okay, and She's a governor of the ANZONA conference in year 2017. And also currently, Wendy is the president of Australian New Zealand Orthopaedic Nurses Alliance. So, we would like to welcome Wendy to actually give a talk for this session on compartment syndrome. However, we're going to give her a few minutes. Before that, I'm going to introduce you a bit about Malaysian Orthopaedic Nurses Association. Saya amat-amat menggalakkan saya selaku Presiden untuk Malaysian Orthopaedic Nurses Association amat-amat menggalakkan semua jururawat ortopedik supaya daftar untuk association ini. Kita ada banyak yang kita dapat contribute pada jururawat ortopedik. Of course, dalam masa pandemik ni, we have a lot of masalah kan. Kita tak dapat buat conference dan sebagainya. We have a lot of intention to do a lot of project through MONA itself, Malaysian Orthopaedic Nurses Association. However, due to the pandemic, we have this, some of the program that we really wanted to do have been stopped. However, of course, this education session will also be ongoing. Yeah, from of course, this session will be given by the local speaker and also daripada international. We want our orthopedic nurses to actually, gain all the knowledge, and of course, dalam masa akan datang, we will also create an FB page, untuk members sahaja, where we will have a program such as Sembang Santai Orthopaedic. We will have a live discussion, and also we would like also to hear from all the members. So please do join Malaysian Orthopaedic Nurses Association. Banyak yang kita boleh discuss, because we also volunteer ourselves to be a mentor to all the orthopedic nurses yang mana hendak menjalani pengajian. Contohnya, if you are interested to do degree in orthopedic nursing ataupun berdasarkan degree in nursing tapi you nak buat research on orthopedic pun, kita boleh, we are approachable, we can be your mentor, or even if you want to do master or PhD in nursing, we don't mind being your mentor throughout the journey. And of course, daftar, we are here to support you, and we have many matron, also sisters, and also nurses that work. Dekat dalam association ni, the member itself bukan terdiri daripada matron sahaja. Kita ada lecturers daripada banyak university. So therefore, please do join us. So lepas ni mungkin kita akan kenakan registration fee lah for people that attend. Tak banyak, insyaAllah takat RM10 je. Supaya kita dapat menjana association kita. So I hope this will benefit you. So Wendy, are you ready? Maybe.
Yes, I am.
Okay, Wendy, I've introduced yourself, and I also, have taken the time to also introduce Mona and to the, all the people here. And I hope, and I'll give the floor to you to start with the presentation.
Thank you very much for inviting me to speak. I'm very, very pleased to be speaking to my Malaysian nursing colleagues in orthopaedic nursing. And we have a wonderful relationship between ANZONA and MINA, and we're very, very pleased to see how well everything's coming along. I've had the pleasure of meeting a few of you in Perth,
yes,
and in Australia when you have been here. And I look forward to many more opportunities once the international borders are sorted. Indeed. To meet you all again, which would be wonderful. My screen is now working for my presentation, but I'm not sure that it will work for the video, but that's good. You can see the presentation now. So what we're going to be talking today is about compartment syndrome, which is a very important topic for orthopaedic nurses. It's a condition that needs rapid recognition and rapid diagnosis to prevent someone from losing a limb. and it can be very, very deceiving because a lot of the classic signs and symptoms of compartment syndrome show very, very late. So we'll be going through those during this session. Right, great. I do have a screen coming up.
Yeah.
Compartment syndrome is basically it's increased tissue pressure in a closed osteofascial space or a compartment. So what happens is surrounding all through our body, we have lots of compartments. Surrounding our muscles is a really tight, tense, fibrous tissue called fascia. And traveling through there is not only the muscles, it also surrounds the blood vessels and also the nerves into a compartment. It's made of collagen. It doesn't expand very well. And there's very little ability for it to expand if for any reason there's an increase in volume within the compartment, such as bleeding or such as edema, or if for any reason that there's an increase in pressure. So what it does is it shuts down the blood supply, it closes down the tissue perfusion when there is an increase in pressure within that area. So that leads to inadequate tissue oxygenation of not only the muscle, but also the nerves in that area. It can't decrease its contents, you can't get rid of the muscle. The only thing that it can do is to close down the blood supply to be stopping that pressure within the system. And that's the way that you get reduced perfusion. Classifying it, there's several types. What we're going to be concentrating on today is much more to do with the acute injury. So we will be looking at the incipient and also the acute compartment syndrome. We'll just touch very, very briefly on chronic, just mainly to mention that it is something, but we don't see much of that in the hospital situation. That's more happening out in the community and with sports. So we will focus much more on the acute injury and what we do tend to see in hospital. So the incipient means that there's an impending compartment syndrome likely to develop unless intervention takes place. This is something as orthopaedic nurses we are really, really good at dealing with. We're really good at preventing this as well, seeing it happening nice and early, and just by something as simple as elevation or releasing a constrictive dressing, usually we're dealing with it at this stage and no harm is done to the limb. Acute is when it goes for prolonged pressure within that system to actually start to be damaging the tissues and decrease perfusion of that area. Chronic, as we were saying, or it's like an exertional, is when there's a whole increase in muscle activity and a temporary rise in pressures. This we see quite often in sports people who are really bulking up with their muscles, and the large muscles are taking up a lot of the compartment, and they can get a lot of pain and trouble when they're exercising and when they're increasing those pressures. But what's happening in those cases is as soon as they're resting, those pressures are going back down again and it's not causing too much problems. Okay, so what we need to be doing is focusing on that incipient or emerging compartment syndrome at that stage to be addressing it nice and early, and then we avoid any further problems for our patients. Most commonly compartment syndrome involves the leg and the forearm. It's the most common places that we're going to see it. It's particularly below the knee and around the tibia. And that's an area of the body where the fascia surrounding the muscles are really, really tense, really tight, and there's not much area of give. We do see abdominal, we do see also the forearm tend to be affected as well. But the most common area that we're dealing with as orthopaedic nurses tend to be below the knee and around the tibia. And as it's saying there, it can affect other parts of the body as well. So we'll have a little look at around the tibia and fibula as well. And we've got a cross section here and it's showing the 4 compartments that are surrounding the tibia and fibula. What we do is we can see, as well as those muscles, we've got blood supply and also nerves travelling through. It is the anterior compartment which tends to be the most affected by compartment syndrome that we see. The causes and things that we need to have a high level of suspicion with is closed fractures. It's not impossible for an open fracture to have compartment syndrome, but it's much more unusual because as the open fracture is happening, the ends of the bone have actually sliced through the fascia and decompressed that compartment. Okay, so any of the pressure, any of the fluids, it's very easy for them to be leaking out within a open fracture. That doesn't mean that the other compartments surrounding it that haven't been decompressed can't cause a compartment syndrome. Doesn't need to be a fracture to cause it. We can also get it with severe soft tissue injuries, crushing injuries as well. And this is one of the most common areas that I've seen compartment syndrome within the acute hospital setting. One that comes to mind is people that have had a drug or an alcohol overdose, and they may have a limb that's trapped under their body while they've been very low in consciousness. It's been pinned under their body for some time, and there's all the decreased perfusion, decreased blood supply, and then they've gone into a compartment syndrome in that way. And yeah, believe it or not, that is actually the most common that I've seen. And by the time they're presented to hospital, they already have compartment syndrome. Tight plasters or anything that is very restrictive over the limb, drug-induced state, which I've mentioned, all of those sort of things can happen. Sorry, that didn't come up, did it? Here we go. So the possible mechanisms. We've got 4 possible mechanisms which are tending to cause. First of all, anything that's going to decrease the compartmental size, such as your really tight dressings, particularly if they're circumferential and pulled too tight around the limb. Otherwise, if dressings or bandaging has gone on and then swelling has happened underneath that, anything that is decompressing or pressing on that area as well. Localized external pressure or over distraction. So for traction, if you think about the area around the muscle, and if we're putting way too much weight onto our traction, that's pulling that compartments out long and narrow, and that's decreasing the volume of that compartment. So that can also decrease the blood supply to that area. So we're always checking with traction after we're putting it on or when we're maintaining it to make sure that neurovascular status is okay. Anything that increases the contents as well, whether it's bleeding, edema, a vascular injury, or also an infusion that has infiltrated. And again, I've seen this where a IV is tissued in someone's forearm, and all of that tissuing has just kept going. All of the intravenous fluids are leaking into that compartment, and that's caused a compartment syndrome too. Any causes that can increase the capillary permeability, which is something to have trouble saying when you're on a webinar. Yeah. So post-ischemic swelling, exercise, seizures, trauma, burns, and also orthopaedic surgery. So anything that's creating that capillary permeability, and I hope that I don't have to keep saying that word, will also can cause a compartment syndrome. And increased capillary pressure as well, such as a venous obstruction. So going over the pathophysiology of what tends to happen is the fascia, as we say, it forms a confined space for muscles, blood vessels, and nerves to be sitting within. If there, for any reason, is an increase in the fluid accumulation or an external compression, this leads to increased pressure within the compartment. That pressure has nowhere to go because it can't go outwards because the fascia is holding it tight. So pressure is then exerted on the blood vessel walls, squeezing them shut. how long this takes. Okay, nerves without a blood supply or with a lower blood supply will show damage in just under 30 minutes till they're really starting to get damaged. That damage becomes irreversible after about 2 to 4 hours only. Now think about when you're sitting somewhere, maybe it's a lecture like this, and you've got your legs crossed. Sometimes it's only really quite quickly until you can be getting those pins and needles feeling, and you move your legs around to get the blood supply back through. That's that very, very start of not quite compartment syndrome, but just those nerves not getting enough blood supply. They let you know fairly quickly. We don't go into compartment syndrome because we do something about relieving that pressure and getting that blood supply through. But it is a very, very quick process for nerves to be damaged. Muscles take a little bit longer. They start to be damaged after about 2 to 4 hours. And after 6 to 8 hours, that damage is reversible because what you're looking at is necrotic muscle with that. So they survive longer, but once that necrosis comes in, that is permanent damage to that as well. When we're looking at this time frame, this is just one shift, one nursing shift, and someone can lose a limb. So it's a really important thing for us to pass on to our student nurses and our junior staff that we're supporting as well, that this is really, really crucial, and it's a very short time frame for a limb to be damaged and to have time to act on that as well. Right, so I'll just move over to the next slide. So 1 second, I'm just putting a light on where I am.
Yeah.
That's it. Right, so just going over that, injury compression leading to more swelling and bleeding. What we're seeing is that increasing pressure, muscle anoxia, so that's just catching up. As the muscle anoxia is happening, what's happening is you're getting a great big histamine release. The histamine release from the muscle damage will create even more edema, more swelling, and it's just a vicious cycle. Keeps leaking into the area, the pressures just keep getting worse. You get a further increase in pressure and it can't correct for itself. And this will keep happening if we're not intervening to do something about the pressures. Okay, and it's a very vicious cycle that just keeps happening. Sorry, I didn't realise there was animation on the screen. Okay, so what do we need to recognise to be able to do something about it? And what we're looking at is they quite often can call it the 5 Ps or the 6 Ps as well. Pain is the first sign that we're looking at, and it's a very good early sign, and it's something we just need to be thinking about all the time. It's so important with pain. What it is it's an unrelenting pain. It's a pain that doesn't seem to be in line with the injury that the person has. But the other thing that is a real alarm for us is that it's a pain that is unrelieved by the pain control that they're having. Okay, so if we've given someone some pain control, they should be getting an effect from it. They're not getting an effect of it. That should be enough of an alarm bell for us to actually do something about it, looking into it further and thinking straight away, is this a compartment syndrome? So it's a really important message to get through with all of our orthopaedic nurses. When we give pain relief, go back and check that it's worked, not only for the comfort of the patient, which is super important as well, but also this is a really important sign as far as our neurovascular status goes. It's an early one. It's something that we can try and pick it up while it's emerging as well. Most of our other signs are late, and by the time that we see them, the patient's limb has already been compromised to a certain degree. We're also checking on the skin tone and checking it against the person's normal skin tone for them as well. The other limb gives us a really good baseline so that we can compare to the other limb to see if there's any pallor of the area. Paresthesia, the pins and needles, are a nice early one. Numbness is a very late sign. Okay, so by the time it's numb again, we can probably anticipate that there's already quite a lot of damage to the area. Paralysis and that motor movement, we've seen that the damage to the muscles takes quite a bit longer for it to happen. So by the time that we're seeing the paralysis with that is a very, very late sign. An extremely late sign, and people quite often think, oh, look, what's going to be a sign of compartment syndrome? And they'll say, oh, look, there's no pulses. We've checked the pedal pulses, everything's fine, they're okay. They don't have compartment syndrome. But pulselessness is a very, very late sign. What happens is the pressures within the compartment should usually be around about 0 to 8 millimeters of mercury. Okay, pulses we do not lose until it's almost up to their diastolic blood pressure, okay, within that compartment. So if someone's got a diastolic of 80, we're looking at a pressure of 80 within that compartment before that person loses the pulses. And as we know, 30 is around about the sign that we would actually decide to do a fasciotomy. So by the time it's got up to 80, it's really, really high before the pulses go. So by the time pulses are going, the limb is likely to be lost as well. The 6P that you will quite often see described is also poikilothermia, where the temperature of the limb as well is very cold. Okay, so this wasn't a compartment syndrome, but it's a really nice slide to really describe what we're talking about with this one. This was a patient who came in after a complete dislocation of the knee, and he actually came in with the his neurovascular status already really quite compromised. And we can see the foot that's on the right side of your screen there is very, very dusky colour compared to the one on the left. Okay, so again, hopefully we will never see this with the compartment syndrome, and hopefully we've picked it up a long way before this, but I just thought that was a really, really good example to show you of altered neurovascular status. But if there's one take-home message, don't rely on pulses, okay? So because it is such a late sign.
Yeah.
Okay, sorry, can anybody hear my dog in the background?
No.
Apologies if you
No,
can.
not me.
He's scratching and crying at the door. I'm just going to let him in so that he will stop crying.
No worries.
You can tell when people are working from home, can't you? Right, I'll just get my little spot here again. Okay. Right, and also keeping in mind with a lot of those signs and symptoms that we're using a lot of regional blocks now within orthopaedics, and we're losing that early sign of pain. So what we need to be doing is actually getting hands-on, feeling the limb, because what you will feel is when someone is starting to get a compartment syndrome, it gets really quite tense and hard, and you can feel for the edema around that limb. And when you're starting to feel really quite tense around the limb, you know that you should have a high level of suspicion for them with a compartment syndrome. But certainly the regional blocks, wonderful for our patient care, but it does make it a little bit more tricky as far as assessing for neurovascular status. And patients that may be unconscious, they might be uncooperative, children might be a little bit more difficult to get information from as to how they're feeling. So talking about, oh, is it feeling tingly? The pins and needles, they may be able to relate to that. And also patients with dementia or delirium, again, it makes it quite tricky to be assessing for that as well. Okay. Okay, when we were talking before about intravenous infusions, this is not the actual photo from where I was involved. This is one that I've got on the internet. But I did have a situation where I was called into an intensive care unit to advise on a limb to a person whose limb was into this position, and they just wanted to know get an orthopaedic opinion as to why. What had happened was they had an IV infusion that had tissued. People hadn't realised that it was infiltrating in, and you get quite a clawed position of the hand when you're seeing compartment syndrome within the forearm or the hand as well. So unconscious patient, you start to see, hopefully you will see it a lot before this, but you can start to see those changes in position and a Volkmann's contracture in this case as well. When I did see that patient, as soon as I felt the limb, it felt as hard as concrete, okay, because it was really quite an established compartment syndrome by that stage that hadn't been picked up. And you can feel it. It just felt really hard. It felt really swollen. It felt really tense. And that's something that we can keep an eye on for our patients, as well as the colour and the warmth of the limb as well, if they're unable to tell us. So basically, we need a high index of suspicion, and diligent observation is required to make the diagnosis for it. How we diagnose is by putting a needle in and measuring the pressures of the needle. The one that I'm most familiar with is brand Stryker, and it's a manometer that they can pop in, and then you can actually test the pressures. If someone is unconscious or unable to tell you the information, then yes, go ahead, measure the pressures, because that is the thing that's going to be able to tell you definitely whether there's a problem. As I said earlier, 0 to 8 is the pressure that should be within the compartment. Traditionally, they said anything over 30 should go straight to fasciotomy because they're definitely compromised. But now there's a feeling that it relates into the person's blood pressure as well. So if there is a difference of 30 from their blood pressure to the compartment, or less than 30, sorry. So for example, if their diastolic blood pressure is low and it's 50, then the threshold for pressures would go all the way down to 20 because it's 30 difference, okay? So there may be a lower threshold for them to be doing a fasciotomy.
Do you have a picture of the test, the equipment that being used to check the pressure?
Not on me, but it looks like a syringe, and it's right at quite a large bore needle, so it's almost like a knitting needle, so they are quite painful. But if you look up Stryker needle for compartment syndrome,
okay,
yeah, that will show you. Some people will also use an arterial line, so anything that's got a manometer, they'll be able to use that.
You mean that the doctor have to like poke the patient with those things to measure?
Yeah, they put the needle into the compartment and set it near the muscle.
Okay.
And then they just put it's about 1/3 of a mil of saline in, and that will give you a pressure reading on the manometer and let you know what the pressures are in there. But if ever in doubt, then it's worth doing that. We keep it in our emergency departments, and we tend to keep it within our theatres as well, so that we can know where we can get pressures tested. If there's a dusky looking limb, we wouldn't test the pressure because we know that it's compromised. Or if it's pulseless, we wouldn't test because we know we would.
It's already a clear sign.
Yeah, it's only if we're unsure that we would test. So if suspected, identify early to prevent muscle damage and nerve damage, and prevent through elevating the limb as well. And we want to stop anything further from happening. So by elevating the limb to around about the level of the heart, making sure that it is elevated, that will help with bringing the swelling down. We used to put the limbs up really, really high, but what they want to do is still keep the perfusion happening and the blood supply to that limb. Okay, we remove any constrictive dressings that are around that area as well. We try and identify the cause. We keep close neurovascular obs onto that area. And as soon as you can, inform medical staff. So if it is needing a fasciotomy, that they can be getting ready to go to be getting the blood supply back into that area. If you do have two of you, if one of you can be releasing the constrictive dressings or cutting the plaster or anything that needs to be doing, while the second person is actually informing the doctors, that will save time as well.
Yeah, it's simultaneously.
That's it, because it's big emergency. You want to get onto it as soon as you can.
Yeah.
Now, this is a little bit of old research, but I've found it very, very effective. So if someone has a plaster cast on, and we know that we can split the cast to try and get the blood supply back into that area, if you just split one side of the cast, it will only decrease the pressure by a certain amount, okay? It's just come down, is that 20%, isn't it? If you split it on both sides, you get a 65% fall in the pressures. So it's much more effective to be splitting through both sides of the plaster. If you split the padding that's underneath, or the web roll as we call it, then you'll get a further fall again. So it's right up to 75% pressures will fall by making sure that you're going through both sides of the cast. You can turn that cast into a back slab so that your fracture is still nice and supported. But make sure that you cut through the soft padding underneath the plaster as well, because that's going to be most effective at getting the blood supply through. Fractures can always be reset if there's a problem, if we lose the alignment of the fracture, but the damaged nerves can't be. Okay, so if in doubt, I would always split a plaster, split it on both sides, have the limb resting in it like a back slab, but I would give the limb the best chance to recover from there. In addition, a couple of the other things we can do is ensure that the patient is normotensive if we can. So the better that their blood pressure is, then the better that the perfusion is that's going to that area. Quite often they may be trauma patients, so they may be hypotensive. And if that can be addressed as well, maintaining their homeostasis is going to give them the best chance. And if their oxygen levels are low, making sure that they're getting oxygen, because we're wanting to get as much oxygen into those tissues as well. The medical management, first of all, measuring those compartment pressures like we were saying, and if it is high, going on to fasciotomy and splitting right through down to the fascia via operation as well. Okay, this is some photos of some fasciotomies that have been done. What they do is that they do the fasciotomy bilaterally, so on both sides of that limb, because if one side of compartments has been compressed or been high pressures, chances are the adjacent compartments have also been under pressure as well. So they get a lot more effect of blood supply back into the areas if they do a double fasciotomy on that limb. Okay, what we have here in these ones is, we're not doing this quite so much now, but what we used to do was we used to put staples either side of the fasciotomy wound, because as you can see, they burst quite open when it comes down to the muscles. And then some people call it shoelace, we used to call it bootlace. The little ties that come in, and we would be tightening them little by little and allowing that to, you know, bring those wound edges together. We're tending not to do that now, because now with the negative wound pressure devices or the vac dressings, we're actually tending to use the vac dressings over the top of them as well, with or without split skin grafts to close them up. But this was a really effective way of bringing the wounds back together and the apposition of the wounds. But certainly the vacuum assisted closure has allowed a lot more healing with that.
How long do you leave it, you know, before you close it back? Like,
we really do them quite individually, because it will depend on, really depends on the pressures coming down for the people. Some people, we find that we can close it up fairly quickly because the swelling's come down. Other people, the limb remains really quite swollen.
Okay.
And so we do it very much on an individual basis. Will also depend if further tissue needs to be debrided. So if that has been a lot longer till the fasciotomy's happened and there's a lot more damaged tissue through there, it may actually need to go back to theatre a couple of times to be debrided, and then we'll just close it very, very slowly. The other thing is the quicker a fasciotomy is done, the quicker that it's healing afterwards, because there isn't a lot of damaged tissue underneath there. But the more devitalised tissue under there, the longer it's going to take for it to heal as well. So we don't have a set time. Okay, complications. Obviously, anywhere that there's been some necrotic tissue is infection. Contractures, if it's been allowed to stay for too long and the nerves are too damaged. Crush syndrome, where the muscle anoxia starts releasing myoglobin into your blood supply. That is necrotic to your kidneys, and people go into kidney failure and they're going to rhabdomyolysis with that as well. Again, with the people that have had a limb crushed underneath them or crushed under, for example, a building or a wall, when that's releasing all of that fluid back in, and they can go into acute renal failure with that. Nerve impairment, loss of limb function, so that didn't come up, did they? And it may require amputation as well, which is a big risk with it as well if it's just been without a blood supply for too long. Oh, sorry, that jumped off. Is that still up on your screen?
Yeah, I can see that.
Okay.
Your conclusion.
Yeah, there we are. So don't rely on pulses. As we've said, think pins and needles and think pain. Always have a high level of suspicion and know those early signs to have a little look for. Prevention, as far as, and this is what we again are really good at as orthopaedic nurses, making sure that we're elevating limbs when they're injured, people that are coming back for theatre, getting those limbs elevated just as part of our normal orthopaedic nursing care is preventing a lot of this from happening. Early detection when it does happen so that we can avoid that long-term damage. Do what you can to relieve the pressure as soon as you can and notify medical staff immediately. So whether that's removing dressings, taking some weight off the traction, splitting a plaster, doing that, whatever you need to do, because the blood supply getting back into that limb is the most important thing. And being aware it only takes one shift to lose a limb for a patient. So it's really important that we are identifying it as early as we can and acting on it very quickly as well. So that's the end of my presentation. Has anybody got any questions on any of that?
Okay. There's one question I can see in the chat group is, how do you test for compartment syndrome? I mean, I do understand. I think what they meant is that, the pressure that you were saying. Yeah, because we don't do. I've been here for I've been doing orthopedic nursing for a really long time. I haven't seen those, those kind of pressure thingy that you mentioned. Because what we do is just we only depend on the 6P and our circulation chart and to identify if the patient have compartment syndrome. Yeah.
No, that's certain. And if you could have a little look at those needles, they do give you a very definite way of knowing whether it does need a fasciotomy or not. So I'm just trying to answer that with the start of my video. And again, my little cursor's missing. So I apologise that you can't see me here. Yeah, but again, pulselessness, if, you're losing the blood supply as far as looking at the colour of the limb as well, that may be enough for them to decide to do a fasciotomy on that. But the striker needles are good because it gives you a really definite answer with that, and you can relate it into what the patient's blood pressure is so that you know whether you need to do the surgery or not.
So ada apa-apa soalan, anybody have any question, you are free to ask. Is massage good for compartment syndrome?
Is massage good? Just trying to think if it would be. It's not something that we've necessarily had a look at, and I wouldn't be able to say no. But yeah, sorry, I'm back on your screen now. But certainly, I'm just trying to think, because I don't know that there would be enough in there to bring.
Because in Malaysia, we kind of like more towards the traditional, the cultural thing, massage. We call it urut. Urut, yeah, urut. I'm not sure whether you have heard it. It's kind of like it's a massage, but mainly people would just like opt for that. It kind of like a complementary, complementary medicine. They will use like traditional oil, and if they see any swelling, and most of the patient, the first thing they do is just like do massage. Those are the problems usually we have. Try to convince them this won't go off with you just massaging.
No, certainly in the very, very early parts of an injury, it may assist with helping with the edema, but I would think more your rest, ice, elevation, compression at that stage before the pressures have gone up. Anything that's going to reduce swelling is going to help prevent. So I would think maybe as a preventative, but once it started to kick in too much and the pressures are going up, I wouldn't say that it would assist with that. And someone that's in nerve pain may tolerate it not very well with that as well, because the compartment syndrome pain, it's anybody that's had nerve pain for any reason will know that nerve pain, very, very strong pain. So whether the massage would help with that, I'm unsure, but might make a good research project to have a little look and see if it does.
Conventional research project. So another one more question. What is the hallmark sign of compartment syndrome?
The pain.
The pain. I agree with you. The thing is, what I found is most of our nurses, of course, in the setting that I work in, the focus is more towards the pulse. However, we kind of like miss off the pain, because like you said, it's more towards the analgesic. Okay, probably not enough analgesic for the patient because it's too the weight. Maybe the doctor have to give more painkiller, those kind of things. The mindset is already set based on that.
That's it.
Yeah, because what you have presented really put an alarm is that the pain itself is the first measure for us to know whether the patient is already towards going towards compartment syndrome. So
that's it, and that's where you can get it in the early part of it. Pulses are good to let you know there's definitely a problem. As far as if the pulses are not there, it tells you a lot of information. But if the pulses are still there, it really doesn't tell you very much. That makes sense. It's more that pins and needles, pain. I had a gentleman that was in a Thomas splint traction one time, and he was in a huge amount of pain and they couldn't get his pain under control. So I went in to have a look. They asked me to have a look at the traction. What had happened was the bar of the traction was sitting right on his fibula head. It had just rested on his fibula head. And you know that the perineal nerve runs over the top. So it was just pressing on his nerve. And he was, screaming in pain, lots of pain. All we had to do was just move the traction so that it was off his fibula head and not resting on it, and the relief straight away from that. And again, that was that nerve pain. Even though it wasn't a compartment syndrome, it was a good example of what it would be like with compartment syndrome. That it's very strong pain. With that. Unrelieved. Unrelieved by pain control.
When the patient complain of pain, don't just associate it with the fracture pain or those kind of thing. We need to look further than that, part of
That's
it.
it. And the key is once they've had pain control, go back and check.
Yeah.
So go back and check, has it had the effect that you would expect?
Mm-hmm.
And if it's not working, then alarm bells, we need to look further.
Yeah.
Mm.
Like you said, it will only take one shift to lose a limb,
That's it.
Satu shift, I'll say it in Malay. Hanya ambil satu shift waktu kerja kita sahaja untuk pesakit kehilangan kaki disebabkan kita tak fokus macam mana nak mengelakkan compartment syndrome ni. So satu shift saja. Daripada situ kita kena tahu betapa pentingnya assessment towards pesakit yang mana ada fracture, especially kalau ada close fracture, yang mana kita kena tengok dengan lebih teliti lagi lah. Yeah. And part of that, Wendy, extravasation, like you said, patient on IV fluid. What we patient on IV fluid having a compartment syndrome is also a kind of a problem where our nurses does not associate with that. When we mention compartment syndrome, it's always fracture. Most of the nurses don't associate extravasation, a kind of like incident with compartment syndrome.
Yeah. That's right. But if it allowed to continue with the stabilization, that's when it can go into compartment syndrome of the forearm.
So compartment syndrome can even happen in every ward. It doesn't have to be orthopedic wards. So, So everybody thinks, compartment syndrome is like orthopedic business and nothing to do with other nursing business. But when it comes to extravasation, patient having IV fluid, when the fluid have been running towards the compartment and everything, and that can cause compartment syndrome, and patient can even lose their limb due to that. Those are the things that even you have brought it up. So that's why I remember, because we have cases that patient develop compartment syndrome, which is not in orthopedic ward, but everybody, find it so kind of like surprised, because, this only happen in orthopedic ward. But they don't associate other things with compartment syndrome.
No, and just on the IV catheters, the Australian Safety and Healthcare Commission have just released the Australian standards on caring for peripheral IV catheters. And so if you look up, I think it's, safety and quality, and look up peripheral IV, you'll be able to get the new Australian standards. They've only been released about 2 weeks ago as to caring for IV catheters with that as well. We've got a link to it on our ANZONA website. Our ANZONA Facebook page. So people can have a look at that as an extra resource as well if they like.
Yeah. So do you guys have any more questions? Ada tak soalan?
Yes, I'm Kamil. Wendy, I've got a question for you. I have the interest of managing pain among patients with compartment syndrome. So what is your advice or your views, despite having pharmacologic agents, what are the other options for pain management for patients with compartment syndrome?
Okay, for the chronic or for the acute?
It could be acute. Yeah.
Okay, so rather than more pain control for them, it's really addressing what has caused the compartment syndrome, because more pain control isn't going to provide any more comfort for them. So whether it's releasing the constrictive dressing, whether it's elevating, finding the cause of what is causing the compartment syndrome, and again being mindful that the medical staff need to be brought in at this point to be assessing whether they do actually need to have further surgery done to stop them from losing their limb. So yeah, further pain control is not the way to go. It's really escalating the care and making sure that the compartment syndrome cause is being addressed, or that we can get blood supply back into that limb. Does that answer the question?
Kamil, does it answer your question?
Yeah, I just wonder because some places they use like cognitive behavioral therapy. I don't know whether it works well for some patients or not. Yeah.
It may in the initial part, but really what you're wanting to do is addressing the blood supply, to get the blood supply back into that limb. And for the compartment syndrome, you know, that's the most important thing, is that you're stopping that pressure from building any further, or you're doing something to release that pressure within the limb. So that would be my advice.
Wendy, I would like to introduce you to Kamil. Kamil is actually a lecturer at our university, Islamic University in Malaysia.
Oh,
He's he have actually he's basically now attached to the nursing faculty there. So
excellent.
Yeah, he's a member of Malaysian Orthopaedic Nurses Association. So he's on board. Yeah, helping me out now. And so well, we have another question, Wendy. So does oxygen therapy, hyperbaric therapy help with compartment syndrome?
It would take too long to get it set up. So really the main thing that's going to help is getting a person straight to theatre and doing the fasciotomy, because by the time that you've got hyperbaric chamber organised, person in there, it's just too much of a delay for that happening. It may assist in the chronic, because the chronic is not quite as much an emergency for it to do. But certainly the acute, it would take too long. Surgery is and the fasciotomy.
Fasciotomy is the right thing to do. True.
Yeah, and if they can get them to surgery within 30 minutes, that's the sort of time frame that you're looking at, that you're wanting to act on it. Very quick to save that.
Well, any more questions? Wendy, it's nearly 1 hour, mashallah. Thank you very much, because I was surprised. There's a lot of questions, and this is very informative. Sometimes when we always hear from our local presentation, it's the same thing. So it's good to hear from somebody outside. So it's very interesting for me when you stated that if you split the cast at one side, you only reduce like 30% of the pressure, and 60%, 65% if you bivalve is on the both side. Those kind of things is good to hear, which is something which is different than what we have presented before.
That's it, and cut the dressings too, open the hole.
Yeah, of course. We call it autobahn. The padding, we call it autobahn. So you always have to remember, when you bivalve, you need to cut the autobahn.
That's it. Yeah. And I'm always happy to come back and present anything further.
Yeah. Like I said, it's nice to hear from somebody from outside, so that we learn from each other. Of course, we can benefit this a lot. So we'd like to thank ANZONA for helping us. And it meant a lot for Mona and also all the Malaysian orthopedic nurses.
Thank you very much, and thanks very much for everybody for listening today as well.
I guess that's it. Thank you everyone, and please fill in the form, your registration form and everything, and do register with Mona. We have a lot of other activities, inshallah. So thank you, Wendy.
Okay, thank you.
Have a good day ahead. Bye
bye.
Okay. Bye. Assalamualaikum. Bye.